Thank you everyone for coming to Friday Chalk Talk. Today's topic is going to be palliative care in idiopathic pulmonary fibrosis. I'd like to introduce Dr. Kathleen Lindell, PhD. She's an associate professor of nursing with a joint appointment in the College of Medicine and the Mary Swain Endowed Chair in Palliative Care Health. She is a graduate of the St. Francis General Hospital Professional School of Nursing and the University of Pittsburgh School of Nursing, where she received her BSN, MSN with a specialty in pulmonary medicine, and PhD. Dr. Lindell was formerly a pulmonary clinical nurse specialist at the Penn Lung Center and participated in development of evidence-based programs to advance health of patients with lung disease. She was the executive director of the support program directing patient support and education at the University of Pittsburgh, Dorothy P. and Richard P. Simmons Center for Interstitial Lung Disease. Her path of research is directed toward improving the quality of life for patients with advanced lung disease, specifically idiopathic pulmonary fibrosis, and their family caregivers. And she's here to speak with us today about the importance of palliative care for patients with IPF and her research in that area. So thank you for joining us, Dr. Lindell.
Thank you for the kind invitation. So I'll get started. I'm trying to move my slide. Okay, I have no disclosures to report. And if you're on Twitter, my hashtag is Kathleen Lindell, and then the movement Pallipulm, which I'll talk about in a little bit. So the objectives for today's talk are to provide some background material on the burden for patients with IPF and their caregivers, to present findings from a nurse-led palliative care clinical trial, and then to provide evidence on hashtag Pallipulm movement. So the burden of IPF. I always like to start with this patient's story. So the impact of IPF. I work with patients with IPF for specifically for 20 years, and prior to that with general and advanced lung disease for an additional 10 years. Patients often report that IPF comes out of nowhere. They just attribute it to normal aging, and they really don't have a true hold on what's happening. So they have difficulty recognizing the disease magnitude. And to complicate matters, disease progression varies. We know that median survival is 3.8 years and that antifibrotics may extend survival, but do not reverse the disease. So this is a picture of one of our patients in Pittsburgh. This is Frank, and Frank gave us consent to share this. So this is probably similar to your geography and topography. You'll see this is a classic Western Pennsylvania yard. And Frank brought this picture into pulmonary rehab and was so proud of himself. He has a gas lawnmower to which he attached his e-tank, and he's using 15 liters per minute in this picture. Anyway, he was really proud of himself, but the pulmonary rehab staff said, Frank, you can't do this anymore. Like, you're just waiting to blow yourself up. But this is in the fall of 2017. And probably 6 weeks later, Frank had an acute exacerbation, ended up in the medical intensive care unit. He was on the lung transplant list as a candidate. He ended up on ECMO. He ended up getting a lung transplant. So it just kind of shows that how the course can just advance with an exacerbation. Anyway, so IPF and other progressive pulmonary fibrosis. So I want to introduce this term, progressive pulmonary fibrosis, because there's a kind of a movement in the literature that you might see it as PF-ILD, progressive fibrosing interstitial lung disease. These are all progressive pulmonary fibrosis. They're trying to reach more of the other patients who have a known cause of pulmonary fibrosis that is progressive. So if you take a look on the left side of this slide, all of these are associated with a shortened lifespan, a variable disease course, tremendous symptom burden, impact on caregivers, limited treatment options, a need for supplemental oxygen, and a need for palliative care. And on the right column are just a few of the manuscripts that support this. Overall, we know that the patients have a poor quality of life. Patients also experience a myriad of symptoms. And if you take a look in this cartoon, patients experience anxiety, depression, deconditioning, fatigue, cough, and shortness of breath, all impacting their quality of life. And then this slide shows the potential disease courses. So this is what's most challenging to me, is that there's no way for a patient to be able to predict how their disease course will advance. So there are some patients that the disease will progress and they'll be dead within a year. They often, most often have an exacerbation, and they have a decline associated with that and a pretty significant drop. They may recover, but they'll never go back to what they were, and they'll just continue on this trajectory. And so in relationship to time, it's, as I mentioned, the median survival is 3.8 years for these patients. So back when I was post-dissertation and starting as a new faculty member, we did some focus groups with patients, and this was published in Heart and Lung in 2016. And it really illustrated that the burden on caregivers. So caregiving for patients with ILD significantly impairs their health-related quality of life, particularly the emotional health. So this particular caregiver was a husband, and he said, when my wife first found out, she kept coughing, and I kept telling her to go to the doctor. She had a biopsy, and the report said IPF. I Googled it, and what I read wasn't what I wanted to read. We asked if we could go to a specialty center, and were told that she wasn't sick enough. She died the next month. She died a week before her first visit scheduled at our center. Another caregiver reported that just overwhelming symptom burden for their loved one, particularly a cough. And this woman reported she was the working spouse, so she had to work to maintain the insurance because her husband could no longer work. And so she said he just kept coughing at night. And she said, I would go to work, and she said I'd be yawning, almost falling asleep. And she said, my coworkers would ask, why didn't you go to a different bedroom so you didn't have to hear the cough? She said, but I would feel bad. I couldn't tell him I was going to work on 2 to 3 hours of sleep. And we asked them what their thoughts were of the word palliative care. And one spouse said, I'm afraid if we talk about the future, he will think that I know he's going to die. So these are just a few of the burdens that caregivers report. So I received funding from the National Institute of Nursing Research and a K-23, and then I had some small funding from Foundation Three Legs Partners. And so I started this study, integrating early palliative care for patients with IPF and their caregivers. So this was a nurse-led delivery of an early palliative care intervention, looking at the impact it showed impact on caregivers, but we studied it in both patients and caregivers. So our goal was to determine the feasibility, acceptability of an early palliative care intervention compared to routine care in patients with IPF and their caregivers. If you take a look on the right column, that's the schema, that's the book, it's the intervention. It's entitled A Program of Support. And this is a book that I wrote based upon my clinical experience working with these patients. So the acronym is symptom management, understanding the disease, pulmonary rehab, palliative care, oxygen therapy, research participation, and transplantation. All things that I felt in working with these patients that it was important for them to be aware of. Our hypothesis was early introduction of nurse-delivered palliative care would improve knowledge and preparation for end of life, patient-reported outcomes, and advanced care planning in IPF patients and their caregivers. This was a randomized controlled trial with an intervention arm and a usual care arm, and our recruitment goal was 80 patient caregiver dyads over a 2-year period who were diagnosed with IPF in the past year. And we aligned it with 3 clinical visits over a 6 to 8 month period. And just to add this caveat, when I did my dissertation, I did a disease management program for patients with IPF and their caregivers. It was also a randomized controlled trial. But patients, they came for 6 weeks for 2-hour sessions, and they learned about all about their disease. And one of the things that we had difficulty with recruitment because there were barriers to being able to attend 6 weeks of courses. So that's why we aligned this with their clinic visit. So in our results, so in this consort table, we assessed 136 patients and found them to be eligible. We excluded 60, 28 just refused to participate. 32 said they would like to participate maybe next time, but because they were too fatigued. So we randomized 76, which was 56% of the eligible. So what happened? We randomized them based upon their clinic day. So we had clinic Monday morning, Wednesday morning, Thursday morning, and Thursday afternoon. So patients on Monday were randomized to receive the intervention. Wednesday were randomized to receive usual care. Thursday morning was intervention, and then Thursday afternoon was usual care. We did that up front, and we with our statistician, knowing that it might cause a limitation. But the reason we did that was because it was the same physician in each of those clinics. So they would see the same physician, and so it would avoid contamination. And what resulted is we ended up with 50 patients in the intervention arm and 26 in the usual care. So it ended up being 2 to 3, or a 2 to 1. So 70% completed the intervention, and 15 did not. And these were because of death. And this was a 6 to 8 month course. So these patients died, possibly received a transplant. And then we had a few that dropped out because we were a specialty center and they came a distance, and they didn't want to come back for the distance. They wanted to stay closer to home. And it was very comparable in the usual care arm. 73% completed the intervention, 7 or 27% did not receive it. They either, the reason was they either died or received a transplant. So feasibility was limited in this study. So acceptability, there is no validated instrument to measure acceptability. So we created a measurement tool to rank satisfaction. It was like a disease thermometer with the intervention content to meet educational needs. So a scale of 1 not being satisfied to 10 being very much satisfied. And so this is in the intervention group of individuals who completed it. So overall satisfaction you can see is a 9, and then the IQR is 8 to 10. They received the booklet. I forgot to mention, it was delivered by our nurse interventionist. She read the book to the people in the intervention arm. We had a website. They liked it, but not many went to the website. Of those that did, they found it to be okay, and they liked the timing. They really liked the nurse. And then this is the percent who looked at the website and then shared it with their family. So our initial impact in regards to efficacy, the patients demonstrated an increased knowledge and completion of advanced care planning, but there was no impact on stress, symptom burden, or quality of life. In regards to caregivers, if we take a look at this first table, baseline outcomes for caregivers' knowledge, preparedness, and confidence. So it says advanced care planning, but that's over here for the post. So in arm 1, this is the intervention arm compared to arm 2. The knowledge, there wasn't really much change in that, or at baseline, they were similar in knowledge, preparation, and confidence. But if we take a look at this table 1B, the end of intervention outcome and the change of outcome from the baseline, you'll see that there was a significant improvement in knowledge, preparedness, and confidence in the caregivers. And advanced care planning, it's interesting. The statistician came to me and he said, Kathy, he said, you have data on caregivers for advanced care planning. He said, I thought we were only measuring patients. So I went back to the nurse interventionist and she said, well, when I hand them the advanced directive, she said, I don't want them to feel like I'm singling them out. So I give them both one. And we found that the caregivers had an improved rate of completion of advanced care planning. It wasn't significant though. So in conclusion, a program of support was, our feasibility was limited. We had high attrition. 39% of the participants died or were transplanted before the study was completed. It was acceptable to both groups. The initial impact showed that, as I mentioned, patient participants noted improvement in knowledge and increased advanced care planning completion. And caregivers noted a significant improvement in knowledge, disease preparedness, and confidence in caring for the patients. So this was published in November in the Annals of ATS. And then our next steps. I did the study in Pittsburgh. I relocated. I was recruited to Medical University of South Carolina in November of 2020. And so it was good timing because I had finished this study. So since I've been at MUSC, I've obtained intramural funding from the South Carolina Telehealth Alliance to adapt this for telehealth delivery, and we're in process of doing that now. And then I've submitted an R01 to explore this delivery via telehealth and expand it from just IPF to all progressive pulmonary fibrosis. And then we did some follow-up work. I have a mentee working with me and really going back and taking a look at these caregivers. So we did a scoping review. This was published in the fall. And we looked, it was an invited opportunity, but the guidelines were very strict. It was a 18-month period. So we took a look at manuscripts, and the search terms were caregivers, pulmonary fibrosis, and palliative care. And there were a total of 15 manuscripts that we included. Now, the thing that jumped out to me right away were there were 8 that involved direct patient and or caregiver input, and then there were 7 that involved the voice of the healthcare providers about and researchers about patients and caregivers about what they thought they needed. I was a little taken aback I thought we really need to have the patient's voice and their caregiver's voice. And what we learned was that caregivers have many unmet needs and face many challenges while providing care. There's the challenges of oxygen, social isolation, and then impaired quality of life. And caregivers also stated they wanted to be engaged early and better supported throughout the disease trajectory. And then this AARP caregiving report came out the year prior, and it showed that most caregivers or carers are 50 years of age or older and often face their own morbidities. So I'd like to give special thanks. So when I was at Pittsburgh, I ran the patient support group, and we always had a yearly golf outing. So if you take a look in this picture, there are patients. We would have oxygen donated by our hospital DME. There are family members. There are faculty and staff and friends. And the whole idea of this was we wanted these patients to understand and appreciate that, that life goes on and they have to keep living. So we did this for 15 years. This raised about $10,000 for us each year. And we used this to offset our support group needs. And then lastly, in closing, this is one of our patients. And she said, please share this around the world. So her name is Joan, and Joan said that when she got the diagnosis of IPF, she realized that this is pretty serious and there's still a lot left for me to do. So she went to Australia. She was fortunate she had the means to do so, but here she is dancing with her supplemental oxygen. So she really kind of serves as an inspiration for patients. And then lastly, I would be remiss if I didn't talk about this, but in my new role as the Endowed Chair in Palliative Care Health, we have a DNP in Lifespan Palliative Care at MUSC College of Nursing. Here's a website for more information. You can also Google it. But this is an online program where nurses, postmasters can receive their DNP in Lifespan Palliative Care. And so with that, I'm going to stop sharing and come back to you.
Thank you so much. It looks like Marty has a question. He's got his hand raised, and then there's a couple questions in the chat that we'll get to as well.
All right. Thank you, Kathy. That was wonderful.
Thank you.
And thank you for all the work you've been doing on it. I've read some of your previous review articles, in particular, the one from 2020. It's a nice jumping off point for all sorts of things, even though it seems like it reads like a sort of a selling for pulmonologists for our utility. But my question is about advanced care planning. So definitely a hot topic right now.
Oh, yeah.
And you've got this perfect illness with tremendous uncertainty, right? You can have subclinical or slowly progressive, or they can just fall right off the cliff. What's your approach? What's your language? How do you talk to people and help them prepare for what might be?
Well, so I have to tell you, one of the biggest challenges is getting the physician to talk to the patient about it. And so I developed a very close relationship with the physicians that I worked with when I was at Pitt, and I now have an equally, group here at MUSC. But what I found, there's several things. The first is that patients often don't appreciate that it's a serious illness or the magnitude. So we did a study where we looked to see where all of our patients who had IPF at our center, where they died, and if they had a referral for formal palliative care. And there were 4 key things. Most of them, the majority of patients got to us 2 years after their diagnosis. And so you think about that, like if the median survival is 3.8 years, so we're already behind. They get to the first visit, and there are papers out there that report that this particular set of patients often has several new patient consults with different physicians. So we're just like losing time. And in that, the other thing that we found in our study was that 34% died in an ICU setting after their first visit with us. Wow. And so the conversation may not have even occurred. It's still like, well, let's confirm after, test what exactly you have and come back in, 3 to 4 months. The other thing that we found were that of the people who died, the majority died in a hospital setting, and only 13% had a formal referral for palliative care, and it was the month of their death for comfort measures. So I always, my thing that I really like to advocate for is just advocating for awareness that this is a serious illness. And I like to give the example is if you were a doctor, or if you were a patient rather, and someone said to you, you have lung cancer, think about your response versus, that's 3 syllables, versus you have idiopathic pulmonary fibrosis, that's 12 syllables. So I think we lose a lot right from the very beginning. So it's really important to speak in the patient's language. And one of my mentors is John Hansenflash, and I was with him at the University of Pennsylvania for 11 years. And he would always spend a lot of time at that first patient visit. And he would always say, you know, you have a serious illness. We are going to hope for the best, but we're going to prepare for the worst, to kind of like just set the stage that this isn't like, or that this is serious. So we've done some other work, and in the Pulmonary Fibrosis Foundation, there's a paper just published last week in Chest on providers' perspectives in the PFF, the Pulmonary Fibrosis Foundation Care Center networks across the United States. And it's a nice paper to review, but what we find is that there's not a lot of discussion of palliative care at the beginning. And the challenge too is we have those patients that live a long time. So, you have patients, the disease course being so variable. So hopefully that answered your question in a long roundabout way.
Thank you. So there's a couple questions in the chat about calculations of the health-related quality of life and caregiver burnout. How do you assess for that? And are there anything available online that we can point to for those things?
So quality of life, I'm glad that someone asked that question. So one of my other mentors, Jeff Zigris, has developed a pulmonary fibrosis specific quality of life instrument. And, but he said to me, I'm going to warn you. He said, when you study quality of life in these patients, yes, this sounds grandiose. We're going to help everybody with their quality of life. He said, but realistically, their quality of life is not going to improve because their disease is going to continue to advance. And so they they'll have shortness of breath. They'll have, cough, fatigue, anxiety, depression, just fear of the unknown because of this. So quality of life, I've actually changed my thinking about quality of life. And I think I was like, man, I'm going to improve everybody's quality of life, but it's really hard. I think a more important thing is to assess their symptom burden and address with using symptom management. So if they're having shortness of breath, get them involved in pulmonary rehab to maximize what they can do. Sometimes early on, that's a really great thing. As the disease advances, don't hesitate to use opiates to treat symptom burden. Cough is, assess cough. Cough is, earlier in the slides, cough can really be challenging for a lot of these patients. So addressing symptoms early on. And then there was a second part of that question. I forget.
The second part was about assessing caregiver burnout and tools available online, if there are any.
There's one called the ZARIT, ZARIT, caregiver burden instrument. I haven't used it yet. We have it in our grant. We intend to use it. That's the one that I'm aware of.
Okay. Well, I know that there are a couple other questions in the chat, but we're just about at time. And so I want to be respectful of everyone's time and your time, Dr. Lindell. Thank you so much for taking the time to share your work with us. And it's been very eye-opening.
Thank you all. And if you're looking for resources for your patients, the Pulmonary Fibrosis Foundation has wonderful patient resources.
Perfect. Thank you so much.
Thank you all.
Bye, Kathy. Thank you.
Bye. Thanks.